All right, so I'm going to get started. So hi, everybody. Thank you for joining me. Today, my CE presentation is called Cancer Crisis, the Management of Oncologic Emergencies. So as for disclosures, I don't have any disclosures. So our objectives today, we're going to talk about 3 different oncologic emergencies, which are hypercalcemia of malignancy, malignant spinal cord compression, and superior vena cava syndrome. So for each of the oncologic emergencies, we're going to talk about the epidemiology, pathophysiology, some signs and symptoms, how we diagnose them, and the treatment as well. So before we get started, I just wanted to talk about what is an oncologic emergency. So it's defined as an acute and possibly life-threatening event that's directly or indirectly related to a patient's cancer and or its treatment. So sometimes patients will actually present with an oncologic emergency, but they haven't been formally diagnosed with cancer yet. So it's really important for patients who already are diagnosed that we prevent oncologic emergencies from developing, and detecting them early is really important. So as pharmacists, we can play a role by encouraging our patients to report any symptoms they may experience promptly. So this slide is just showing you some different oncologic emergencies. The ones that we're going to talk about today are in red, but there's even more than just this list. This isn't a all-inclusive list. There's so many more than this also. So the first oncologic emergency that we're going to talk about today is hypercalcemia of malignancy, which is actually the most common cause of hypercalcemia in the inpatient setting. So first, the epidemiology. Up to 30% of patients at some point during their disease course will develop hypercalcemia of malignancy. But there is some good news. The yearly prevalence for all cancers is fairly low. That's really due to the prophylactic use of giving patients with bone metastases bisphosphonates or denosumab. The most common malignancies are listed for you here. They're really the most common because they commonly metastasize to the bone. Like, these malignancies are the most common ones that have bone metastases. And then the median survival here in older studies is about 30 days, and in newer studies is actually longer. But despite the availability of more effective treatment, the outcomes are still kind of poor for patients who don't respond to treatment. So this data, these median survival times, doesn't include patients who aren't on treatment yet. This is just for patients who are really not responsive to their current treatment and then go on to develop hypercalcemia. So the pathophysiology, there's different mechanisms through which hypercalcemia can occur. This one is the most common. It's parathyroid hormone related peptide, PTHRP, I'll refer to it as, release. So these are the cancers it's most common in. So one thing that is important to understand when we're talking about this is what parathyroid hormone itself is. So that's naturally produced by our body. So under normal physiologic conditions, when the calcium in your body is low, the parathyroid gland senses that. So it'll release parathyroid hormone. So that parathyroid hormone will increase the activity of 1-alpha hydroxylase, which is just an enzyme that converts vitamin D to its active form. So then that has a few downstream effects. So one of them is in the bone. So it'll cause increased bone resorption, which just pumps calcium into the blood. It also will prevent renal excretion of calcium in the kidney. And then it also promotes calcium absorption in the intestine. So the net effect that's seen really is this increase in calcium and decrease in phosphorus. Now, PTHRP, I like to think of it as fake PTH. So it's actually secreted by the tumor regardless of calcium levels. So that's really important. So there's nothing telling it to stop producing, but it is structurally similar to PTH. It works in the same ways as PTH. So it does increase the calcium. It increases serum calcium through kidney and bone resorption. But the one difference, though, is this red X over here. It actually doesn't work in the intestines because it doesn't increase active vitamin D. So the net effects are the same. It does have cause an increase in serum calcium and a decrease in phosphorus. So another pathophysiology is paracrine stimulation of osteoclasts. This is less common, and it's really associated with bone metastases. So in this picture on the right, you can see the tumor cells are actually like right on top, right next to the osteoclast. So they'll secrete signaling molecules that are going to go and promote the osteoclasts to go in and break down the bone. So that's really the primary role of osteoclasts. So this commonly occurs more in breast cancer and multiple myeloma because those really do have a lot of bone metastases seen. The other ones listed are pretty rare. There is vitamin D analog secretion. That's when vitamin D analog is secreted by the tumor cells, more commonly seen in non-Hodgkin's and Hodgkin's lymphoma, still overall like a rare pathophysiology. And then ectopic parathyroid hormone is when the tumor itself is actually making parathyroid hormone. So the clinical presentation, I like to say it, bones, stones, moans, groans, and psychiatric overtones. So bones, you have your skeletal bone metastases causing pain, kidney stones. The moans are really like GI complaints. Groans, the ones in red are really signs of a true emergency. So like patients presenting with coma or cognitive changes, that's a sign of like a severe true emergency. And then some other symptoms, there's some cardiac symptoms that include a shortened QT interval, arrhythmias, the renal symptoms, polyuria, polydipsia, dehydration. Those really make sense because like we talked about, the kidney's key in excreting the calcium from your body. So if your calcium's high, it's going to try to compensate by excreting calcium in the urine. But so these ones in red really are signs of true emergency. And then patients commonly present with osteoporosis just because really going back to the pathophysiology, you're breaking down the bone. So as a result, you develop osteoporosis as well. Now, how do we diagnose and stage it? It's really based off of serum calcium levels or corrected calcium or ionized calcium. So just as a reminder, the normal serum calcium ranges from 8.5 to 10.2. Serum calcium, it does measure bound and unbound calcium, and about 40% of the calcium in your serum is bound to albumin. So that's why it's really important to get an albumin level on these patients, just to make sure that the calcium level is accurate. So corrected calcium plays a role for patients with hypoalbuminemia. So that way you can make sure that the calcium is actually like accurate and it doesn't look falsely high or low. And then ionized calcium could be obtained if you think the serum calcium is inaccurate, but that alone could also be inaccurate. So it does have some limitations. So treatment, before we do anything else, we really want to make sure we're providing supportive care for our patients. So one of the ways we could do that is correcting other causes of hypercalcemia. Vitamins trap is the mnemonic to remember that. Also identifying possible drug causes. So these are some drugs that could cause hypercalcemia. And then identifying nephrotoxic medications is really important as well because of all the renal implications that we had discussed earlier. So vitamins trap that I just alluded to, this is the mnemonic. So the ones in red are just things I specifically wanted to mention. So a lot of patients are seen taking vitamin D supplementation. So that could be contributing to their hypercalcemia. Something else, thiazide diuretics, those increase renal tubular reabsorption of calcium. So that could be contributing as well. And then renal failure, as we've said before as well. So now the treatment overview. So like I said, we stage it based on mild, moderate, and severe based on what your calcium levels are. So depending on what stage you're in is really kind of how we're going to treat you. So everybody gets normal saline. If you present with mild hypercalcemia, you'll get a bisphosphonate if you have symptoms. And then calcitonin would be added if there's no response in 48 hours. Moderate, you're already getting bisphosphonate, and then calcitonin is the same rule. If there's no response in 48 hours, you could add that on. For patients preventing with severe, those are the ones that you want to give everything to. So everybody, like I said, gets normal saline. So just something to note is only about 1/3 of patients can actually be treated with normal saline alone. So the mechanism, it really just creates a dilutional effect. It causes increased renal excretion as well. So you have increased renal perfusion to promote that excretion of calcium. It works pretty quickly and it lowers serum calcium an okay amount. Something to take into consideration though is volume overload. So what we could do is give patients diuretics. So you could give furosemide, but it's not without risks, of course. So hypovolemia, really overshooting with the loop diuretic is a possibility. And electrolyte disturbances, as we know, furosemide does affect a lot of electrolytes. So step 2, this is our bisphosphonates. So our main options are zoledronic acid, 4 milligrams IV over 15 minutes, and then pamidronate 60 to 90 milligrams IV over 2 to 24 hours. So the biggest thing too is we want to give these patients IV because oral bisphosphonates are going to take longer. Remember, this is an oncologic emergency, so we do want to make sure that we're treating it quickly. It does take a little bit of time though to start working, about 2 to 4 days. So that's when it starts to work, and then it hits its nadir at about 7 days. So that's really the maximum lowering effect will be shown in about a week after giving it. The mechanism is shown on the side over here. So it's just showing that it inhibits the osteoclast function. So then you have reduced bone turnover as a result. Does have really good calcium lowering potential. It's the best out of all of our options, but it isn't without adverse effects, of course. We all know about osteonecrosis of the jaw, bone pain, more electrolyte abnormalities as well. Something to take into consideration though is renal dysfunction. So for zoledronic acid, you don't need to dose adjust if they have mild to moderate renal impairment, which is defined as creatinine less than 4.5 in the package insert. But if they do have renal impairment, you could consider a longer infusion time. And then also for pamidronate, you could dilute it in a 1 liter bag and also consider a longer infusion time. So I said earlier, you would give zoledronic acid or pamidronate. So how do we really know which one we want to pick? So there was a trial that was done. There were 2 concurrent, parallel, multi-center, randomized, double-blind, double-dummy trials, and it was looking at the efficacy and safety of zoledronic acid and pamidronate for hypercalcemia malignancy. So they used patients with either moderate or severe. So they were given either zoledronic acid 4 milligrams or 8 milligrams, or they were given pamidronate 90 milligrams. So the results of this trial showed that patients who were given zoledronic acid, more of them had a normalized serum calcium by day 4. So half of the patients by day 4 already had a normal serum calcium. And then it also showed the patients who got zoledronic acid had higher rates of complete response by day 10. So the percentages are here. Not too much of a difference between the different dosings of zoledronic acid, but compared to pamidronate, it was statistically significant. And then it also did have a longer median duration of complete response for the patients who got zoledronic acid. So that's really important as well. It's actually a pretty big difference that you could see here. So our step 3 is calcitonin. So the dosing is here for you. It's a parathyroid hormone antagonist. So remember, parathyroid hormone secreted when your calcium is low with the goal of increasing calcium. Now calcitonin is the opposite. So it's secreted when calcium is high with the goal of decreasing serum calcium. So it decreases renal calcium and phosphorus reabsorption and decreases bone resorption. So it works fairly quickly within 2 hours. So its use really is to buy some time until your bisphosphonate kicks in a few days later. It lowers calcium an okay amount. The biggest thing to consider is tachyphylaxis. You want to make sure you limit the use to 72 hours because your body will become sensitized to this exogenous calcium that it may no longer respond to the exogenous calcitonin, and it may no longer respond to the endogenous calcitonin that your body makes. So like I said, its role really is 48 hours after a bisphosphonate if there's no response or if they present with severe hypercalcemia. So there are some other treatment options that you could use as well. There's prednisone. That's really just indicated for lymphoproliferative malignancy. It works by decreasing mononuclear cell calcitriol production. Works in about 3 to 5 days. There's also denosumab. That's indicated for if you fail bisphosphonate, or more commonly, there's a contraindication to using a bisphosphonate. So if your renal function is very poor, you could give patients denosumab instead, since there's no renal dose adjustment. The mechanism, it's a monoclonal antibody, and it's directed at rank L. So rank L is what activates your osteoclasts, which are causing the bone resorption. Pretty similar adverse effects to the bisphosphonates though. So to wrap up hypercalcemia, I have a patient case. So we have ML, 65-year-old male presenting to the ED for dizziness and a subsequent fall. He endorses polyuria, polydipsia, abdominal pain, constipation, and nausea. His past medical history is listed here for you. And they did a CT on him, and it shows that there's lytic lesions concerning for multiple myeloma. So these are his home meds, all listed here for you. And his labs, his corrected calcium is 13.8. So my first question is, what would you stage his hypercalcemia as? Would you say that it's mild, moderate, or severe? Moderate, yes, good. And then, so knowing that it's moderate, can anybody tell me what we would want to treat him with? Bisphosphonate is one of them. And then there's one more that everybody gets. That's a hint. Yes, normal saline. So after some discussion today, actually, you could also give D5W as an option, but lactated ringers actually does have calcium in it. So really the concept is we want to give fluids to create that dilutional effect and have them urinate out the calcium. So really just fluids in general. And then if there was no response in about 48 hours, that's when we could consider the addition of our calcitonin. So good job. So now we will move into malignant spinal cord compression. So I have a question first. Can anybody tell me which of the following cancers could have bone metastases? Breast cancer, multiple myeloma, prostate cancer, lymphoma, or all of the above? Kind of briefly actually talked about this. All of the above, correct. Really any cancer can have bone metastases, but actually this list, these are the most common cancers that have bone metastases. So the epidemiology, malignant cord compression occurs in about 5% of all patients with cancer. Most patients who develop it have already been diagnosed with cancer. So it occurs in actually about 40% of patients with pre-existing non-spinal bone metastases. So really this is a oncologic emergency of metastatic disease. So our most common malignancies are the ones that are most likely to metastasize to the bone, which I just talked about. And then the survival, it says 4 to 6 months, but it really also does depend on the underlying malignancy, because there are some malignancies with a more poor prognosis than others. So that's something to keep in mind really throughout this presentation. Whenever I talk about median survival, this is not necessarily true for everybody. It could be a lot longer or a lot shorter. So the pathophysiology, there's different mechanisms that it could occur by. One of them is you could have the bone metastases actually infiltrating the epidural space, leading to a cord compression, which is seen right here. You could also have the tumor going in and actually destroying the vertebrae, causing a vertebral collapse, which is seen over here. So you can see the bone is like kind of worn down, and that's from the tumor going in and actually doing that itself. You also could have a paraspinal mass that extends into the epidural space. So also just as a note, it could occur anywhere along the spine, but it does occur most commonly in the thoracic vertebrae, which is this red section right over here. Now for our clinical presentation and diagnosis, back pain occurs in almost everybody. I like to think of it as a prodrome because it's really present for a prolonged period of time, so like a couple months, and it precedes any of the neurologic symptoms. Now, once you develop these neurologic symptoms, that's when you're really showing that you have a true cord compression and a real emergency. Because once you develop these neurologic symptoms, paralysis is kind of soon to follow. So these are the neurologic symptoms. So like limb weakness, difficulty walking, sensory loss, bladder or bowel dysfunction. So that's why early recognition is especially important in malignant spinal cord compression. Like I said, if your treatment's delayed by even just a few hours, you could develop paralysis and that could be permanent. It is diagnosed with an MRI. That's really our gold standard, or you could do a CT scan as well. This is what it looks like on an MRI. As you can see here, it's actually very noticeable. Like you could see that it's really compressing the spinal cord right here. So it's very distinct when you do an MRI. Now, supportive care is really important. Analgesia, because many patients do have late stage cancer, they're already on chronic high dose opioids. So we want to make sure that we're maximizing our pain management and increasing those opioid doses because this is very painful. And going off of that, it leads me to our next bullet, laxatives for our patients who are using opioids, and then for patients who also have bowel dysfunction. Catheterization is important for patients with bladder dysfunction and bed rest as well. It makes a lot of sense because if you're walking around, you're going against gravity, right? So you're more likely to develop that paralysis. So by laying in bed, you're not like working against gravity. But with laying in bed comes with VTE prophylaxis. So making sure our patients have the compression stockings. If they are high risk for developing like a VTE or a DVT, we want to give them subcutaneous enoxaparin for those patients. So the treatment overview, really our options consist of corticosteroids, radiation, and surgery. So corticosteroids, this is really important that patients have to have neurologic deficits present and the suspected or confirmed cord compression. So it works by decreasing edema and inflammation at the site of the cord compression. So it reduces the total water content in that surrounding tissue. It does show a rapid reduction in the clinical symptoms of those neurologic deficits. The dosing is kind of controversial though. So there's the high dosing regimen and the low dosing regimen. Studies haven't really shown any significant beneficial effects with the high dose versus the low dose. Really, any studies out there have showed that the high dose has a much higher rate of significant adverse effects, such as like GI perforation, psychosis, and infections. And given that these patients have cancer and they're immunosuppressed already, do we really want to increase that risk of infection? That's something that we would want to make sure that is a discussion with the medical team before we give patients the high dose corticosteroids. So really its only role is in severe neurologic deficits. So most commonly you will see the low dose being used. And so radiation and surgery, radiation, it's only indicated for monotherapy if they don't have neurologic deficits. And also it has to be radiosensitive tumors, but hopefully this list looks kind of familiar to you. These are all tumors that are sensitive to radiation, but also the most common causes of malignant cord compression. So if you can catch it early when the patients are having back pain, and you could give them radiation early on and prevent them from developing like the true emergency signs, that would be a really good option for our patients. Now surgery, some indications, you need to have spinal instability, obviously, really for patients who don't respond to radiation or they have a tumor that is resistant to radiation. Paraplegia for a short duration, if it's within a single area, because if it's all throughout the spine, you really can't like operate on the entire spine. And good life expectancy, there is a caveat to that, just remembering that it's not defined, because like I said, it's dependent on cancer type, but we are talking about stage 4 metastatic cancer. So really we're talking like in terms of months. Like these patients most likely don't have like years, like 10 years or anything like that to live. So good life expectancy really is kind of subjective. It is often combined with radiation though. So surgery is also another situation that's a discussion with the medical team. So since we talked about radiation, these are some side effects. So as pharmacists, we could play a role in the management of these side effects, right? So nausea and diarrhea, fatigue, urinary frequency. We could counsel our patients on medications for these, and that's where we really could play a role within radiation. So to summarize the malignant cord compression, it does occur in 40% of patients with bone metastases. Recognizing it early is really important to prevent progression to paralysis. Could be due to either the bone metastases going into the epidural space and compressing the cord that way, or actually destroying the vertebral cortical bone. Our treatment options, we don't really have much. It's corticosteroids, radiation, and surgery. Oops. So now we're going to talk about superior vena cava syndrome, the last of our oncologic emergencies. So the epidemiology, there's about 15,000 cases per year. The most common cancer, as you could see, both small cell and non-small cell lung cancer are on this list, which makes a lot of sense because your lungs and your heart are right next to each other. There's also lymphoma and germinal cell tumors as well, though. It does have kind of a poor prognosis. So when treated with radiation, only about 10% of patients survive after 30 months of presenting. But 30 months, when you're talking in terms of cancer, is not necessarily too horrible, but only 10% of patients is a very low number. And the median life expectancy is about 6 months. But like I said earlier, remember, life expectancy really varies based on the underlying malignancy, as some have more of a poor prognosis than others. Now, so before we talk about pathophysiology, we really should orient ourselves to what we're talking about here. So could anybody tell me what number the superior vena cava is on this diagram? 2, yes, correct. So it's formed by the union of the right and the left brachiocephalic veins. Does anybody know what the superior vena cava does? Like what its role really is in the body? So the superior vena cava, it's a vein. So it returns the deoxygenated blood that's coming from the head, the neck, the upper extremities, the torso. It brings it all back into the heart. So it drains into the right atrium. So over here, you can see, so the superior vena cava is number 2. It's not super clear depending how you're looking at this photo, but it drains into number 3, which is your right atrium. So this is really important to know because it makes a lot of this make more sense. So the pathophysiology, the superior vena cava is a thin wall that's surrounded by rigid structures, making it really easy to compress. The superior vena cava syndrome results from a partial or a complete obstruction of blood flow through the superior vena cava. So that could be due to 2 different mechanisms. It could be due to a thrombus formation within the superior vena cava. It is a vessel of low intravascular pressure, so that easily allows for thrombus formation because if the blood isn't going through with high pressure, it's kind of like flowing in a little slowly. Patients who do have cancer, the genetic changes that cause cancer can increase the activation of clotting factors, putting you in a more hypercoagulable state. So that's something else to take into consideration. Or you could have a tumor that's actually physically compressing on the superior vena cava. So this is a nice photo illustrating it. So here's your tumor, this white thing over here that kind of looks like a pancreas. Your superior vena cava is right here, and the tumor is really like sitting right on it, compressing it. So as you could see over here, the jugular vein, because you have the tumor pressing on it, the blood can't return back to the heart. So this is showing the obstructed brachiocephalic vein as well. Now this makes a lot of sense, talking about our symptoms that patients present with. So one of the classic signs of superior vena cava syndrome is Pemberton's sign. So this is a man shown like at baseline standing there normally, but then you'll see in the right picture when he raises his arms, he has facial congestion, cyanosis, like as you could see, like the color of his skin below his neck here and here. He's really cyanotic, and they'll develop respiratory distress after about a minute. That's just because the tumor is compressing or there's a clot there and the blood is just kind of stuck all in your head. So like I said, the superior vena cava, what it does is it's bringing back that blood to the heart. So it can't get back to the heart. So that's why the rest of your body and your lower extremities become cyanotic. Something else I do want to point out are some symptoms of a true emergency. So the stridor could be due to the tumor being just so big that it's actually obstructing more than just the vena cava, or it can be due to having so much blood just backed up. The confusion and the syncope could be due to a lack of perfusion, which makes a lot of sense because if you can't get blood perfused, you then will have syncope. So diagnosis, there's different ways we can diagnose. Venography is the gold standard for really visualizing and diagnosing a venous obstruction. It's really just an x-ray of your veins. So they'll inject contrast dye continuously through a catheter. So it is an invasive procedure. It also is used with endovascular intervention for patients who have a severe presentation. You also could diagnose it with an ultrasound, MRI, or a CT scan. Now, some treatment following, like I've talked about all the others, supportive care always comes first, right? So one way we can help our patients is elevating their head. That works by decreasing the hydrostatic pressure and edema. There's really no data documenting like how effective it is, but it is simple and without risk. So it makes a lot of sense though, because if you're lying flat, like there's nothing for like you to have like the blood being pushed down versus if you're sitting upright and elevating your head, then that'll kind of like push the blood back into your heart, kind of similar to what we talked about with like gravity and malignant spinal cord compression. The same kind of concept applies here. Another thing is ABCs, airway, breathing, circulation. Like I said, a lot of patients will commonly present with like dyspnea, rest, or cough, or that could be causing them to having difficulty breathing. So you want to make sure that you're giving them oxygen so that way they're able to breathe. Diuretics, there's really not much efficacy data, but in theory, I guess it kind of makes sense how it works because it decreases your intravascular volume. So by doing that, you have less blood like really like stuck up here. Now our treatment overview, there are a lot of treatment options, but I do want to make a disclaimer that there are no formal guidelines that address the management of superior vena cava syndrome. So a lot of this is really just based on smaller case reports and case studies. The chest physicians and NCCN, they did put out some general recommendations for patients with lung cancer. They recommend radiation and or stent placement for symptomatic obstruction. Overall, though, our goals of treatment really are to shrink the tumor, though, and prevent any thrombosis from occurring. So first, we'll talk about chemotherapy. It's a first-line treatment if the cancer is susceptible to chemotherapy and if there's no indication for endovascular stenting. The mechanism, it works by actually shrinking the tumor directly. The cancers that are susceptible to it are listed here, and hopefully this list looks familiar. The most common causes of SVC syndrome are all susceptible to chemotherapy, which is a good thing. So radiation is another possible treatment option. So it's indicated for symptomatic patients. You do need to do a tissue diagnosis, which makes sense because you do want to make sure that you're giving radiation if the cancer is actually responsive to it, because if it's not responsive, you don't want to just give people radiation for no good reason. It does improve symptoms fairly quickly. So there was a systematic review and patients with small cell lung cancer had complete relief of symptoms. 78% of them had complete relief of symptoms at 2 weeks. And then patients with non-small cell lung cancer, 63% of them had complete relief of symptoms at 2 weeks. So it looks really great. but does it actually fix the obstruction? So there was another study done, autopsy studies actually showed the complete patency, which is the vein being like open, expanded, not obstructed. It was only found in 14% of patients, and then partial patency in 10% of patients. Now, 85% of the patients in the study, though, did report relief of symptoms before when they were still alive. So that's something to keep in mind. Yeah, you might be helping the symptoms, which is great, but like, are you really fixing the actual problem? Likely not. The development of collateral circulation could also be contributing to the improvement of symptoms. And it's really like the value of radiation is uncertain before chemotherapy if a patient has a chemosensitive tumor. That's why chemotherapy is first line for if the tumor is chemosensitive. So corticosteroids are another option. They do reduce the tumor burden in lymphoma and thymoma. Thymoma is a cancer that develops in the thymus gland, and that's what produces T cells for your immune system. So it's really just more likely to reduce obstruction in these cancers than any others. So corticosteroids, though, the effects are not formally well studied, and only case reports are what suggests any real benefit. So now we'll talk about thrombolytics. Thrombolytic agents such as alteplase have been used effectively in patients with a thrombosis, but the risk of bleeding with alteplase may be so high that we might need to do a mechanical thrombectomy. So that's when you go in, a surgeon goes in and manually removes the thrombus. So that's really for high risk of bleeding or any contraindication for alteplase. Most experts do recommend anticoagulation after thrombolysis just to prevent progression and recurrence, which makes sense. But there is limited data to support this recommendation because there's no specific anticoagulation recommendations. I did some research on this, and really like different studies use different things. Like some people used heparin, some people used Lovenox, some people used warfarin, some people used DOAC. Like it really, there's no real consensus. Now, endovascular stenting, I've kind of talked about a lot. So here I'll get more into it. It's really indicated if you have severe symptoms that require urgent intervention. So those patients, like I talked about before, presenting with stridor, confusion, syncope, the signs of a true emergency, those are the patients you want to stent. Also, patients who have mesothelioma, it really doesn't respond well to chemo or radiation. So there's no real like oncologic way we could get rid of that. So endovascular stenting is a good option for those patients. It also does provide pretty rapid symptom relief, but it's not without its complications. Of course, it's a surgery, so there's infection and possibly you could have a PE, the stent could move, hematoma, bleeding. Anticoagulation is commonly recommended after stent placement, but the same rule kind of applies. So to anticoagulate or not to anticoagulate. Now, if you have a stent placed and there was a thrombus, anticoagulation is recommended. Either short-term, at least, anticoagulation or antiplatelet therapy, but it's not defined, like I mentioned before, either. So anticoagulation, you could give treatment dose heparin, enoxaparin, warfarin, a DOAC. Antiplatelet, that's really if patients have a high risk of bleeding and you don't want to anticoagulate them. So you could give them clopidogrel, aspirin, or you could do the dual antiplatelet therapy. And then if a patient gets a stent and doesn't have a thrombus, that's where it gets even more muddy. So there isn't any reliable study. There's little consensus from the literature on the indications for anticoagulation, antiplatelet therapy, and which therapy to use. So it's the same options as above, but the bottom line, it really comes down to there being little evidence because this is a pretty rare syndrome. And then the anticoagulation decision really comes down to expert opinion for anticoagulation management. So that's a conversation that would be had with the medical team about if we want to anticoagulate at all, how long we want to do it for, and what we actually do want to give. So to wrap it all up, a summary of superior vena cava syndrome occurs most commonly in lung cancers, lymphoma, germinal cell tumors, could be due to either a thrombus in the superior vena cava or a tumor actually compressing the superior vena cava. Our treatment options are listed all here for you. But remember, not every treatment is right for every patient. So there's some patients who might get 1 or 2 of these interventions for treatment. So an overall summary of oncologic emergencies, remember, it's an acute and possibly life-threatening event, either directly or indirectly related to a patient's cancer and or its treatment. So you really want to make sure that you detect it early, and then as pharmacists, really encourage our patients to report symptoms promptly. This slide just has a summary of all of our treatment options for all of the oncologic emergencies we talked about. So they're all just listed here for you. There's no like guideline for this. That's in the other slides. And of course, remembering the supportive care that we talked about too. So for acknowledgements, I just want to thank Dr. Tyler for reviewing my content. And thank you all for your attention. Does anybody have any questions on anything before we end? And if you haven't already, just make sure that you send your emails to Dana, so that way I could send you the post-assessment questions and you can get credit. I'm not sure if any of you guys saw Caesar's email either. I know there's an issue with the website to get the credit, but he's working on it, so you will get credit. Thank you, everybody. I know he sent an email today. I think he just wants everybody to email him. Let me see, what did he say in the email? Let me end the recording.